All right. So, on behalf of the Middlesex Health Cancer Center, I'd like to welcome you all here tonight. Unfortunately, individuals of Ashkenazi Jewish descent have higher rates of genetic mutations that increase risk for several types of cancers. So, as part of tonight's presentation, you'll learn about those increased risks, what hereditary risk assessment is, and how genetic counseling how genetic counseling and screening may impact personal recommendations for your prevention and cancer screening. My name is Amber Kapoor. I am the Health Education Grants Coordinator for the Middlesex Health Cancer Center, and I'll be the moderator for tonight's presentation. I'm very pleased to have with us tonight two of our certified genetic counselors at the Cancer Center. Amanda Hamblett is a Connecticut licensed and board certified genetic counselor with extensive experience in hereditary cancer risk assessment. She joined the Middlesex Health Cancer Center in July of 2013. She assesses risks for all cancer types with a special interest in hereditary pancreatic cancer and hereditary gastrointestinal cancer. She completed her Bachelor of Science in Psychology at the University of Massachusetts Amherst. She then earned her master's degree in genetic counseling from the University of Minnesota and board certification from the American Board of Genetic Counseling in 1999. Amanda has lectured extensively in genetics, and she has been published in peer-reviewed journals. She is actively involved with the National Society of Genetic Counselors. Kelly Watrous is a Connecticut licensed and board certified genetic counselor. She's worked as a genetic counselor since 2013 and joined the Middlesex Health Cancer Center in June of 2017. Kelly has a Bachelor of Science degree in biology from Western New England in Springfield, Massachusetts, and a Master of Science degree in genetic counseling from the University of Pittsburgh in Pennsylvania. She provides genetic counseling for all types of hereditary cancer and has a special interest in assessing for hereditary ovarian cancer. Kelly is an active member of the National Society of Genetic Counselors. We're also lucky to have a third licensed and board certified genetic counselor on our team, Haywan Park. Haywan joined our team nearly a year ago and has been a great addition to our busy hereditary risk assessment program. And with that, I will turn it over to Amanda, who will be our first presenter for the evening. To Kelly, who will be our first presenter for the evening.
All right, thank you, Amber. So my name is Kelly Watrous, and I'm one of the 3 genetic counselors at Middlesex, and we're happy to be talking to you all tonight about hereditary cancer risk assessment among persons of Ashkenazi Jewish ancestry. So we've been hearing a lot in the media about genetics and hereditary cancer. It's good to understand what proportion of cancers are hereditary as a starting point. Most cancers are actually not hereditary. 90% of cancers are the result of a combination of risk factors labeled here as familial and sporadic. Lifestyle, environment, random chance, and small genetic factors all come together to make up a person's cancer risk. As you can see with the pie chart, 5 to 10% of cancers are considered to be in the hereditary category, which means that a gene mutation is passed down in a family, causing an increased risk for cancer. So to understand hereditary cancer, first, it's important to know that all cancer is genetic, but not all cancer is hereditary. So even though those 2 words sound similar, there actually is a difference. All cancers are caused by genetic damage that occurs over our lifetime. In this picture, the genetic damage is represented by the X's. And once there's a certain amount of damage, cancer occurs. With sporadic cancer, the person has no genetic damage to begin with, but acquires damage over time. These are called somatic mutations. And this is a slower process. Typically, people will develop this type of cancer later in their life. In comparison with hereditary cancer, the person is born with a mutation already. This is called a germline mutation. And this germline mutation causes cancer to develop at a higher rate and at a faster interval. So typically this translates into hereditary cancers being diagnosed at younger ages and individuals with hereditary cancer having a higher chance of developing more than one cancer in their lifetime. So you might be wondering who needs to think about hereditary risk. Here are some signs in a family that can indicate a greater chance for hereditary cancer. So if we see the same or related cancers in 2 or more close relatives, if we see an early age at diagnosis, and we use age 50 as a benchmark here. So if somebody is diagnosed with cancer before age 50, that's considered early age at onset. If somebody has multiple primary or bilateral tumors, for example, a woman having bilateral breast cancer or somebody having bilateral kidney cancer. Rare cancers is another sign we look for. For example, if a male is affected with breast cancer. And then multiple generations affected. So if we see a grandparent, a parent, a child, all affected in the same family. And then finally, individuals from certain populations can have a higher chance of carrying a mutation causing hereditary cancer. Tonight, we're focusing on the higher risk of cancer in the Ashkenazi Jewish population. There are a number of hereditary cancer germline mutations that are more common in the Ashkenazi Jewish population, the most well-known being BRCA1 and BRCA2 mutations, which cause the syndrome hereditary breast and ovarian cancer syndrome, or abbreviated HBOC. So for a quick background in biology, BRCA1 and BRCA2 are only 2 of our thousands of genes. BRCA1 and BRCA2 are actually 2 separate genes. This is a picture of our chromosomes. You can see that we have 23 pairs of chromosomes holding our genes in each cell. And you can see that BRCA1 is on the 17th chromosome and BRCA2 is on the 13th chromosome. Since we have pairs of chromosomes, we have pairs of genes. Therefore, we have 2 copies of each gene, one that we get from our mother and one that we get from our father. So everyone has 2 BRCA1 genes and 2 BRCA2 genes, one of each from each parent. And knowing this becomes important when we think about how these genes are passed in a family, which we'll talk more about in a later slide. So why are BRCA1 and BRCA2 important to think about? These 2 genes are the most common cause of hereditary breast cancer. As you can see in the pie chart, there are other genes that can cause hereditary breast cancer in addition to BRCA1 and BRCA2. Some examples listed for you here, TP53, PALB2, CHEK2. Genetic testing is indicated for all Ashkenazi Jewish women with a breast cancer history. And the American Society of Breast Surgeons actually recommends genetic testing for all women with a history of breast cancer, whether or not they're Jewish. In the past, genetic testing only included BRCA1 and BRCA2, but as you can see, that testing would have missed mutations in these other breast cancer genes. So now genetic testing includes analysis of multiple genes all at the same time, and this is called panel testing. So if somebody was tested in the past, they may actually need updated genetic testing to include evaluation of these additional breast cancer genes. So just as breast cancer can be hereditary, BRCA1 and BRCA2 are also the main cause of hereditary ovarian cancer. And there's a similar recommendation for all women with ovarian cancer to have genetic testing, or at least be offered genetic testing. As you can see here, ovarian cancer is more likely than breast cancer to be hereditary. So the frequency of BRCA1 and BRCA2 mutations is one of the main things that's Jewish about hereditary cancer. 1 in 300 people in the general population carry a pathogenic BRCA1 or BRCA2 mutation, and that's compared to 1 in 40 people of Ashkenazi Jewish ancestry who carry a pathogenic BRCA1 or BRCA2 mutation. And knowing this difference really gives us the ability to get ahead of risk for the Jewish population. We see BRCA mutations more often in Ashkenazi Jewish people, but we also tend to see the same 3 mutations, and we call these the founder mutations. There are 2 founder mutations within the BRCA1 gene and 1 founder mutation within the BRCA2 gene. Overall, 1 in 40 Ashkenazi Jewish individuals carry one of these 3 mutations, as I mentioned. Some additional statistics worth knowing are seen here. 10% of Ashkenazi Jewish women with breast cancer carry a mutation, which is 1 in 10, and 40% of Ashkenazi Jewish women with ovarian cancer carry a mutation, which is 2 out of 5. It's also possible for an Ashkenazi Jewish person to have a mutation somewhere else in BRCA1 and 2, so somewhere besides one of these 3 founder mutations. And genetic testing can vary. Sometimes the test will only look at these 3 founder mutations, and other times the test will completely evaluate the entire BRCA1 and the entire BRCA2 genes. These mutations are passed down from generation to generation through a pattern called autosomal dominant inheritance. Both men and women can carry these mutations, and anyone who carries a mutation has a 50% chance of passing the mutation down to their children. So in this family, the mother has a mutation. As you can see, she's shaded half green, the other half gray. 2 of her 4 children ended up inheriting the mutation. So you can see the middle 2 children have that shaded half green, just like she does, and the other 2 do not. It's important to know it's an independent 50-50 chance each time, similar to the chance of having a boy versus a girl. So every time she was pregnant with each of these children, there was a new 50-50 chance to either pass the mutation or to not pass the mutation. Not everyone with gene mutations will develop cancer. So this is a family tree as drawn by a genetic counselor. The circles are women and the squares are men. Each generation is a separate line, and if somebody is colored in, then they've had a cancer diagnosis. The woman with the arrow had a breast cancer diagnosis at age 35. Her mother is not colored in, but her mother's mother died of ovarian cancer at age 58, and her mother's sister had a breast cancer at age 45. The patient's mother, who would have had the mutation, never developed cancer. And this is something called incomplete penetrance. There's also variability. So all of these people have the same gene mutation, but they all have cancers at different ages and even have different types of cancers. It looks like the patient's uncle would also have the mutation, but it's important to realize that men with BRCA mutations are at increased risk for cancer as well, which we'll go over. So what does it mean to have BRCA1 or 2 mutations in terms of the cancer risks? We wanted to go through some specific risk numbers with you. The first set of bars there, so we have the general population numbers in blue and the BRCA lifetime risks in orange. So breast cancer lifetime risk in the general population is around 12%. That's compared to the breast cancer lifetime risk if somebody has a BRCA1 or 2 mutation, 40 to 60%, so much elevated. Ovarian cancer lifetime risk in the general population is estimated at 1.5%. This is compared to 20 to 40% if that woman has a BRCA mutation. There's also a higher risk for a second breast cancer if a woman has a BRCA mutation, and you can see 10% in the general population compared to 30% with a BRCA mutation. There's a significant difference in ovarian cancer risk between BRCA1 and BRCA2. Ovarian cancer risk associated with BRCA1 mutations is estimated at 20 to 54% compared to ovarian cancer risk associated with BRCA2 mutations, 10 to 27%. It's also important to note that if a woman has a first-degree relative, labeled here as FDR, with ovarian cancer, so a mother or a sister with ovarian cancer, then her risk is higher than general population risk as well. So mutations aren't the only reason a woman's risk could be higher. Just having that family member with a history could be increasing risk by itself. And many times individuals come to genetics to understand what their cancer risks are in order to help make decisions about their health care. And we can use charts such as this one here to give more personalized information. For example, a 32-year-old woman with a BRCA1 mutation has a breast cancer risk of 10% by age 40, 28% by age 50, 44% by age 60, and 54% by age 70. And knowing these numbers can help a woman make decisions about her risk and therefore make decisions about her management. I mentioned that a woman with a BRCA mutation who's had a cancer already can have a higher chance to have a second breast cancer in her lifetime. We can use data such as a woman's age and which gene she carries a mutation in, either BRCA1 or BRCA2, to calculate her risk. She may choose a bilateral mastectomy as part of her breast cancer treatment. This would reduce risk of an additional breast cancer in the future. Men and women with BRCA1 and 2 mutations are at increased risk for other cancers. So far, we've mainly talked about women with BRCA mutations having higher risk for breast cancer and ovarian cancer, but men who have BRCA mutations have a higher risk for breast cancer, up to 8%, as well as prostate cancer, up to 39%. In comparison, men in the general population have a less than 1% risk for breast cancer and a 12% risk for prostate cancer in their lifetime. Prostate cancer can also be diagnosed at younger ages and possibly be more aggressive in these men. So knowing genetic status becomes very important for men as well. Men and women with BRCA mutations have a higher risk for melanoma, which is skin cancer, as well as pancreatic cancer. The average population risk to develop pancreatic cancer is estimated at 1.6%, and it may be as high as 10% if a person has a BRCA mutation. So at this point, I'm going to turn things over to Amanda, who will begin by discussing options for management for BRCA1 and 2 carriers.
Hello, everyone. Thank you so much for joining us tonight. And thank you, Kelly, for that great review of cancer genetics and the risk associated with BRCA1 and BRCA2 mutations. At this point, I'd like to transition to talking about what we can do about risk. Knowing about risk is really only helpful if we can do something, either to lower cancer risk or to find cancer at an earlier stage when it's easier to treat. So I'm going to take a few minutes to review how we can lower cancer risk or find cancers earlier in people who have BRCA mutations. There are actually established recommendations for management of people with BRCA mutations, but even with established recommendations, choosing management is very personal, and each individual will make different decisions depending on multiple factors, including their age, their childbearing status, their personal experience with cancer, as well as other factors. And so the following slides will review the current recommendations for BRCA mutation carriers, divided really into 3 categories of management. 1 is using screening to find cancers early. 2 is using medicines to lower the chance of developing cancer. And 3 is using surgery to lower the chance of developing cancer. So first, we'll talk about screening. And what I mean by screening for cancer is basically using certain types of either imaging studies or blood tests or physical examinations to look for cancer. I know this slide looks pretty busy, but as Kelly reviewed, the largest risk for women with BRCA mutations is the risk to develop either breast cancer or ovarian cancer. And at this time, we have very good screening for breast cancer, which for the average woman includes breast exam by her medical provider each year and a mammogram each year beginning at age 40. But for women with BRCA mutations, we know that breast cancer can happen at younger ages. So we don't want to wait until 40 to begin screening. For women with BRCA mutations, breast exams done by a medical provider should begin at the age of 25 and be done either once or even twice a year. Also at age 25, women should have a breast MRI each year. Mammograms really are not useful in younger women because of the density of their breasts, which prevent mammograms from reliably finding breast cancer. Once a woman with a BRCA mutation is at age 30, then we will begin using mammograms. So at age 30, a woman with a BRCA mutation will have both a breast MRI and a mammogram each year to screen for breast cancer. This type of screening is very good at finding breast cancer early, but for some women, this screening can be very anxiety producing. Surveillance for ovarian cancer is not reliable and often cannot find ovarian cancer any earlier. Unfortunately, ovarian cancers are often diagnosed at a stage where they're difficult or even impossible to cure. And so, despite the limited usefulness, sometimes medical providers will use either a transvaginal ultrasound and or a blood test called a CA-125 to attempt to screen for ovarian cancer. As Kelly mentioned, men with BRCA mutations are also at increased risk for cancer. And so there are also screening recommendations for men. Men with BRCA mutations are at higher risk for breast cancer, and it's recommended that they have a breast exam by a medical provider each year beginning at age 35. And in addition, men who have a significant amount of breast tissue may actually need to get mammograms each year, beginning usually around age 50. Men also need screening for prostate cancer. And this is particularly important, as Kelly mentioned, for men with BRCA2 mutations, because BRCA2 mutations have been shown to have a higher chance of causing aggressive prostate cancers. And so we want to make sure that we can identify those prostate cancers as early as possible and treat them right away before they become a problem. Both men and women with BRCA mutations have some increased risk for pancreatic cancer. But the overall risk for most carriers is actually quite low. And so pancreatic cancer screening does exist, but it's new. The data that we have indicates that screening can find pancreatic cancer, but it needs to be used only in people who have at least moderate risk because the screening is invasive. And so typically individuals with a BRCA mutation and a family history of pancreatic cancer have enough risk for pancreatic cancer that it's appropriate to consider pancreatic cancer screening. We also typically recommend melanoma screening for individuals with BRCA mutations. And this screening is just an exam by a dermatologist, which is not invasive. And melanomas can happen at younger ages for BRCA carriers, so it's very important to be aware of the signs of melanoma. So really, screening is one option that we have to address increased risk for BRCA carriers. And again, the goal is to find cancer at an early stage. But the one thing that screening does not do is lower the chance of developing cancer. There are medicines that have been proven to reduce the chance of developing cancer. And there are medicines that can be used to actually reduce the risk of either breast cancer or ovarian cancer in individuals with BRCA mutations. There are multiple medicines that have been shown to decrease breast cancer risk. One type is called a selective estrogen receptor modulator, and another type is called an aromatase inhibitor. And these medicines can reduce the risk of a specific type of breast cancer called estrogen receptor positive by 50% when taken for 5 years. Interestingly, oral contraceptive pills or birth control pills, if taken for 5 or more years, can reduce the chance of developing ovarian cancer by 50%. So for young women with a BRCA mutation who's choosing a birth control method, oral contraceptives are a good choice because in addition to providing birth control, they lower her ovarian cancer risk. Lastly, I want to touch on surgery as a way to reduce cancer risk. There are 2 main surgical options for women with BRCA mutations, one related to ovarian cancer and one related to breast cancer. I'm going to start with talking about the surgery related to ovarian cancer. So since ovarian cancer really has no reliable screening method and it's often diagnosed at a late stage, it's recommended that all women with BRCA mutations have their ovaries removed to lower the chance of developing ovarian cancer. The recommended surgery is called a bilateral salpingo-oophorectomy, which means removing the ovaries and fallopian tubes. This surgery can reduce the chance of developing ovarian cancer by 96%. You'll notice on the slide that since ovarian cancers tend to happen at younger ages for BRCA1 carriers compared to BRCA2 carriers, the age is different to recommend having this surgery done. For BRCA1 carriers, we typically recommend having this surgery between the age of 35 and 40, whereas for BRCA2 carriers, we do it a little later, typically between the age of 40 and 45. Although it's really all dependent on family history, sometimes we choose to do it even earlier or later. We do know that based on research studies, removing ovaries in BRCA carriers does keep the carriers healthier. Since we have great screening for breast cancer, mastectomy to reduce cancer risk is really considered an option rather than a recommendation. We know that doing a double mastectomy can reduce a BRCA carrier's breast cancer risk by 90%, which is substantial. But it's also a very significant surgery. And the decision to undergo risk-reducing bilateral mastectomy is very individualized and a personal decision, which really often depends on a woman's age, her childbearing status, and her personal experience with cancer. For example, a 40-year-old woman who found out that she has a BRCA mutation versus an 80-year-old woman who finds out that she has a BRCA mutation would oftentimes make very different decisions regarding managing their breast cancer risk. Some women feel very strongly that they want to reduce their chance of developing breast cancer by the highest amount possible. Or they may have so much anxiety with the twice-a-year screening that they feel like mastectomy is a better choice for them. Other women may feel that having surgery when they might never develop breast cancer is not something they want to pursue. They would much prefer screening in consideration of maybe medication rather than surgery. So it's certainly a complicated decision-making process that really needs to be focused on that individual's own situation in life and what they're looking to get out of their management. One important thing to note that's relevant to the Ashkenazi Jewish community and is very specific to the BRCA2 gene is that there is a scenario where if two parents each carry a BRCA mutation, any children they have together are at risk for a condition called Fanconi anemia. Fanconi anemia is a genetic condition that's different from BRCA2 cancer risk, where individuals are at higher risk for developing birth defects, certain cancers, and other serious health conditions, even in childhood. And you can see here on this slide that the mother and the father each have a mutation in their BRCA2 gene, and one of their 4 children inherited both mutations, one from each parent. And that's what causes Fanconi anemia. It is recommended that people with a BRCA2 mutation who are planning on having children, particularly if their partner's of Ashkenazi Jewish descent, but even if the partner is not, consider undergoing genetic counseling and testing to better understand the chance of having a child with Fanconi anemia. I'm going to change gears a little bit here because we've talked a lot about BRCA, but there are other founder mutations that are important in the Ashkenazi Jewish community to talk about, and some of them have to do with risk for hereditary colon cancer. So we know that in addition to having higher rates of BRCA mutations, individuals of Ashkenazi Jewish ancestry have some of the highest rates of colorectal cancer of any ethnic group. The general population risk for colon cancer is about 4.5%, and this rate may be 2 times higher in the Ashkenazi Jewish population. And this is maybe the result of certain genetic changes that increase colon cancer risk that happen to be more common in Ashkenazi Jewish individuals. And so before talking about the specific founder mutations, it's helpful to look at a pie chart similar to the ones that we looked at relating to breast cancer and ovarian cancer, where we look at the causes of colon cancer. And again, you can see most colon cancers are the result of a combination of factors that cause sporadic or familial cancer, but about 10% of colon cancers are hereditary. And the hereditary cancers, the primary cause of them are two different genetic syndromes. One is called Lynch syndrome, and the other is called familial adenomatous polyposis, also referred to as FAP. And so the most common genetic change that causes an increased risk for colon cancer in the Ashkenazi Jewish population is a mutation in the gene called APC. And the mutation itself is called I1307K. And this mutation is actually found in about 6% of people of Ashkenazi Jewish ancestry, or just over 1 in 20 people. Usually mutations in the APC gene cause a hereditary cancer type called FAP, or familial adenomatous polyposis, which results in hundreds or even thousands of polyps in the colon and causes an almost 100% chance of getting colon cancer in someone's life. But the I1307K mutation does not cause FAP, or even the milder version of FAP, which is called attenuated FAP. This mutation causes just a small increased chance of developing colon cancer, probably about double the risk of the general population, which again is about 4.5%. So someone with the mutation may have a colon cancer risk of about 9%. Since this risk is higher than average, it's recommended that anyone with this mutation begin colonoscopies at an earlier age, typically at age 40 instead of age 50. And that their colonoscopies are done at least every 5 years instead of every 10 years. Therefore, it's important to know if a person has this mutation to make sure they're getting the right management. While no one enjoys colonoscopies, this procedure is both a screening procedure that looks for cancer, but it's also a preventive procedure because removing polyps before they become cancer can actually prevent cancer from developing, and is particularly important for individuals who have a genetic risk factor. While the APC mutation is the most prevalent founder mutation related to colon cancer risk, a different founder mutation that causes something called Lynch syndrome is also important because the colon cancer risk and other cancer risks are much higher with this particular mutation than the APC mutation that we were just speaking about. Lynch syndrome is the most common cause of hereditary colon cancer, making up about 3 to 5% of all colon cancers. And Lynch syndrome increases the chance to develop multiple cancers, including colon cancer, uterine cancer, and ovarian cancer, among others. The lifetime risk for colon cancer can be as high as 70% for some people with Lynch syndrome, and the lifetime risk for uterine cancer can be as high as 60%. We do know that there are multiple founder mutations that cause Lynch syndrome, but this particular one in MSH2 has been deeply studied. And we know that about 1/3 of all Lynch syndrome cases in individuals of Ashkenazi Jewish ancestry are due to this particular mutation. And like with BRCA, there are options for screening, risk-reducing medicines, and risk-reducing surgeries for people with Lynch syndrome. For example, screening may include colonoscopies beginning at age 25 and actually repeated every year. Risk-reducing medicines may include oral contraceptives to lower ovarian cancer risk, or interestingly, aspirin to lower colon cancer risk. Lastly, risk-reducing surgery is an option and may include hysterectomy with the bilateral salpingo-oophorectomy to reduce the risk of endometrial and ovarian cancer, or even a colectomy, which is removing some or all of the colon to reduce future colon cancer risk. But similar to making medical management decisions with BRCA, these medical management decisions are very individualized including with Lynch syndrome, and it's very important for individuals to pick the management that works best for them. So, how do you know if you have a founder mutation or another mutation causing an increased chance of developing cancer? Genetic testing can be used to figure out if someone has a mutation, but it's important to have testing done by a quality laboratory. These days, genetic testing is often done to investigate our ancestry, and some of these laboratories offer testing for founder mutations without involvement from a healthcare provider. It's important to note that these tests have limitations. First, they've not been validated to ensure their results are accurate. Therefore, a group called the National Comprehensive Cancer Network recommends that any mutation found on an ancestry type test must be confirmed by a certified lab. In addition, some of these labs provide what's considered raw genetics data that is then interpreted by a third party. Very often, this type of interpretation is flawed. Individuals can be told that they have a mutation associated with increased cancer risk, which they do not have, because this type of interpretation is prone to errors. In our practice at Middlesex, we've actually seen multiple people who were told that they were positive for hereditary cancer risk by one of these companies when they were actually negative. And so inaccurate results from direct-to-consumer tests are something to be aware of. The National Comprehensive Cancer Network says that testing for founder mutations should not be offered outside of a medical framework or clinical trial. And this is because there's hundreds of different genes that can be included on genetic tests. And one test may only look for founder mutations, while another test may look for mutations throughout the entire gene. So having a healthcare provider order the test ensures that the most useful test is ordered for that person that's specific to their personal history, family history, and ethnicity. Testing in a clinical setting is tailored to the history and most often includes full analysis of multiple genes. Many people have questions about whether or not they should get genetic testing. And here are some of the considerations to really keep in mind. Often when we have a family history of cancer, we wonder if our chance to develop cancer is increased. And genetic testing can actually help to clarify if someone's at increased risk for cancer or their family members are at increased risk for cancer. One of the most important reasons to have genetic testing is to clarify if changes to management are indicated. Because if someone is at higher risk to develop cancer, they will have different options for cancer screening to find cancer earlier, or different options for medicines or surgery to reduce cancer risk. Genetic testing is most useful, or also called informative, if it's done on a family member with cancer. However, that is not always possible. So for people who have a family history that's suggestive of hereditary cancer, or from a group with higher rates of hereditary cancer, genetic testing can be very important to help understand their cancer risk. In addition, if a person has a family member with a known inherited mutation, then they have a chance to carry that same mutation. And genetic testing is the only way to determine which family members have the mutation and which family members do not. So when considering genetic testing, it's important really to think about the whole picture, including how genetic testing might impact someone's medical management, their current life stressors, someone's age and stage of life, coping skills, and the effect on insurability. So one of the things that's been a concern for many years is there a risk of discrimination based on genetic test results? There are now laws in place that protect us from genetic discrimination. And what those laws say is that if we have a genetic test that shows that we're at increased risk for cancer, our employer, if they were to somehow find out, cannot use that against us and, for example, fire us based on our risk. In addition, having a genetic risk for cancer is not considered a pre-existing condition. That is also part of this law. There are a few groups that are not covered by this law. One of the groups are people who work for the federal government, including people in the military, who won't have the same level of protection. And the other are people who work for companies with less than 15 employees. The other piece that's not covered by the legislation is our ability to obtain certain types of insurance that would be considered non-essential. That's something like life insurance or long-term care insurance. If we have a genetic test that shows that we're at higher risk for cancer, and then we decide to go buy a new life insurance policy, that company can use that information to determine our rates or to deny us insurance if they believe that our risk is high. And so that is certainly something to consider prior to pursuing genetic testing. And really, a genetic counselor's expertise is in evaluating all of these areas so that each person can make an informed decision about whether to have or to not have genetic testing. And so really, what is genetic counseling? Genetic counseling is really a process of determining what kind of cancer is in a family. Is it sporadic? Is it familial? Is it genetic? And how that impacts the cancer risk for that person and their family members. So genetic counselors typically assess someone's personal and family history and then use that information to determine that person's cancer risks. They also figure out, well, what's the chance there's a hereditary gene mutation in the family? And who should be tested, that person or a family member? The genetic counselor also goes through all of the benefits and limitations of genetic testing, as well as what each kind of result would mean for that person and for family members, and whether specialized screening might be useful for that person, or whether there are steps that person could take to lower cancer risk. And ultimately, the genetic counselor is there to help someone make decisions about genetic testing and understanding risk. At Middlesex, we have a robust cancer genetics program, and we provide hereditary risk assessment for all cancer types. We have 3 certified genetic counselors on staff, as people mentioned, and we're all licensed by the state of Connecticut. We provide genetic counseling both in Middletown and Westbrook, and referrals can be made by a medical provider, or someone is allowed to self-refer for genetic counseling if they want to. And we will assess individuals who have a personal history of cancer, but also people who have a family history or someone who is from an ethnic group that has a higher likelihood of having a hereditary risk. Typically, genetic testing includes analysis of multiple genes, somewhere between 30 or maybe up to 85 genes. I think one of the biggest questions that comes up with genetic testing is, will my insurance cover it and what does it cost? And the answer is, when it's indicated, it's covered by insurance. Now, the definition of indicated is really when someone meets the National Comprehensive Cancer Network guidelines for hereditary cancer genetic testing. But these guidelines are complicated and have many different algorithms to determine who should be offered testing. So, for example, a woman with breast cancer and Ashkenazi Jewish ancestry would meet the guidelines. Or a person who's male or female who has 2 relatives with breast cancer, and one of those relatives was diagnosed with breast cancer before the age of 50. Or a person with 3 close family members that either have colon cancer or uterine cancer would meet the guidelines. And at this time, actually, any individual with Ashkenazi Jewish ancestry, even if they don't have a personal or a family history of cancer, meets the guidelines for genetic testing at minimum for the 3 BRCA founder mutations. And so for individuals who meet the criteria, genetic testing is often fully covered by insurance. When an individual wants to pursue genetic testing to understand their cancer risk, but they don't meet their insurance criteria, laboratories actually now offer a self-pay genetic test, which means it does not get billed to someone's insurance. But in this case, the genetic test costs $250. Genetic counselors always review insurance coverage and costs as one of the considerations when thinking about and discussing genetic testing. So we can't do a presentation without noting COVID and the situation that it's put us all in. Times are certainly different right now, but safe access to cancer risk assessment and genetic counseling is available even during COVID. I know here at Middlesex, we offer telemedicine visits where a person can meet with a genetic counselor remotely, have their genetic testing done from home, and review their results, again, all from home. There's certainly still the option to come in and meet with a genetic counselor in person. So I just want to say thank you to Taya Fallon. She's a genetic counselor at Insight Medical Genetics, and she shared her slides from her presentation that was given for the Norton and Elaine Sarnhoff Center for Jewish Genetics. We have additional speaker with us tonight who will share her experience with attempting to understand the cause of the cancers in her family and how this information impacted her medical care. We would be happy to answer any questions following that next speaker. Thank you very much.
Hello. Can you see me or hear me?
Hi, Karen. We can hear and we can see you. Thank you so much.
Okay. All right. I cannot see myself at all, so I don't know how that looks, and I have to read my little notes that are also on the same screen, so I hope that's okay. So I am 100% Ashkenazi on both sides. My father's side, who came to Baltimore and Pittsburgh from the Austro-Hungarian area of Europe in the mid-1800s, had a lot of cancer. My father's father was one of 7 siblings, and I think they all had cancer. I think 3 or 4 women that had breast cancer. So I kind of grew up just knowing about this. And then when my father's first cousin found out that I was going to college to study environmental engineering, she said, "Oh, you might be interested to know that our family is involved in this research study about breast cancer to find out if it's caused by environmental industrial pollution or genetics." And I was like, "Oh, okay, that's interesting." My dad didn't really know much about it. And, you know, there was no internet back then. So I go off to college and I'm studying environmental engineering. And about a year or 2 later, it's huge, huge news that the gene for breast cancer has been discovered. So I just kind of assumed, oh, that's that thing my cousin was telling me about. I guess I probably have that gene. So I was kind of like operating under this assumption, I guess I probably have that gene. And then fast forward, and jump ahead 20 years. So I'm in my 30s, and I was actually discouraged by 2 different doctors from getting genetic testing or starting monitoring early because, partly because I think my father was an only child. So even though he had a lot of aunts and cousins that died from breast cancer, he did not have any sisters. So I didn't have any aunts and I didn't have any first cousins that had, there just weren't any. So my family history was a little bit, I guess, not first degree. But then as fate would have it, stuff happened and physically, and I ended up having to go and start my monitoring for annual screening and everything like that. So I started remembering what my cousin had told me also about our family participating, and I really wanted to get the genetic testing done, but you know, and having been discouraged from doing that, it's a very scary prospect to find out, do I have this elevated risk and do I have this gene? It's very scary, but and my philosophy has always been knowledge is power. And once you are armed with that information, then as Amanda said, then you can design your monitoring program around that. So I did have a really good experience at the genetic counseling and testing that I did through Middlesex. I was able to somehow make that happen. I don't remember exactly if I was referred by one of the doctors eventually or I self-referred. But anyway, it was a really good experience. And I learned a lot. I learned, I didn't even know what I didn't know, which Amanda was able to educate me about the risk and everything like that. And then one of the really excellent things was that I was able to get a letter from Middlesex Health that explained about what my level of risk was and my need for some like a little bit different tailoring for my monitoring, and that also that would apply to my siblings. So I have 2 siblings who both of whom had much busier lives and less resources than me and less good insurance coverage. So it was actually very helpful for me to be able to give that letter to my sister, and she was able to show that to her doctor and use it to help her get the monitoring that she needed, which would have been more difficult without that input. So that was really a really good outcome. And it was a huge relief to just know and have the information. And I just want to add a little postscript to that. I actually was able to figure out to get in touch with Mary Claire King, who runs the King Lab, and she is the genetic researcher who discovered the breast cancer gene. And amazingly, in her 70s, she's still running the King Lab. And of course, I had this funny idea in my head, like the gene was discovered, case closed, research study over. But as I'm sure the other presenters already knew, but no, as genes are passed down from one generation to the next, so the research study continues on and on and on because they're still running it and wanting to continue looking for possibly other genes and maybe the sports family gene because we are actually not a BRCA family. So even though we were one of the early participants. So I was able to get in touch with her. She remembered my cousin, and then the King Lab sent me a test kit, which I was able to take to my doctor's office and have my blood drawn and also send my blood to them. So I participated in that as well. So overall, just being armed with this knowledge was a really good experience. And I'm glad that I did it. Thank you.
Much, Karen. We really appreciate you sharing such a personal story with us, kind of a look at what genetic counseling means to someone. I think your story also points out something that is little understood about genetic testing and genetic counseling, and that even for individuals for whom no known mutation is identified, there still might be changes or recommended changes to your management for prevention and or screening. So really appreciate you sharing that point and sort of how it impacted you as well. Kind of the relief that comes with having that information. As you said, knowledge is power. So thank you so much, Karen.
Sure, thank you.
Thank you.
And so at this time, we'll move into the question and answer portion of our webinar here. So please submit any questions through the question and answer function at the bottom of your screen. Come through just yet, so we'll give people another few minutes to formulate their thoughts. Or anything else you might want to share after watching tonight's presentation. All right, so we have someone saying, I am an adopted male in my 50s and know that I am of partial Ashkenazi descent. Should I get tested?
So I think that's a great question. Sorry, Kelly, if you're about to answer there. Um, so Ashkenazi Jewish ancestry in terms of genetic testing is defined as having at least one grandparent who is of Ashkenazi Jewish ancestry. So assuming that you have at least one grandparent, biological grandparent of Ashkenazi Jewish ancestry, then yes, you would meet the criteria for genetic testing to look for founder mutations that may influence your risk of developing cancer. And I think it can be particularly important in families where someone is adopted because you really have no family history information. And that can be helpful not only for you, but if you have children or ultimately grandchildren for your future generations to understand their risk and the appropriate screening for them as well as for you. I don't know if Kelly, you have anything else to add there?
No, I agree.
Some messages of gratitude for you speakers. We'll give just another minute to see if there are any other questions before we wrap up. So seeing none at this time. All of our faces are in the way here. So I'll just leave this slide up. This has the contact information for Middlesex Health's, oops, that's what I wanted present. So this has contact information for our hereditary risk assessment program at the Middlesex Health Cancer Center. So our phone number is listed there as well as our website. As I mentioned at the beginning of the presentation, we do intend to post a recording of this webinar to our site so you can check back there for updates. And then once you're on the Cancer Center's main page, there is a section for hereditary risk assessment that you'll see in our menu to the side. Also want to point out that we do have appointments with our genetic counselors available in both our Middletown and our Westbrook Cancer Center locations. So depending on where you're coming from, you can choose from either of those. And with that, we will go ahead and wrap up. I do want to thank all of you for attending. I also want to thank Kelly, Amanda, and Karen for sharing their experience and expertise with us tonight. I know that I've learned something new every time I talk to our genetic counselors. I learned something new. So I found this webinar to be really informative and hope that's been true for all of the other attendees as well. So thank you very much, everyone, and have a great night.
Thank you.
Thank you.